Hello everyone and welcome to the 3-hour crash course. So we're going to first start with health statistics. The leading cause of death in all genders is heart disease. We should know this simply because we call hypertension the silent killer. Lots of times these patients go and they don't go to the doctor or they don't take their medication. These people then put themselves at risk for all the complications regarding hypertension, and that makes heart disease as our number one leading cause of death in both male and female. We also need to know that as we age, we get atherosclerosis, so of course this is going to lead to heart disease. So you may be asked a question on your exam and you need to pay attention to whether it's asking leading cause of death in all ages, or as we get into the next one, is it asking for the leading cause of cancer deaths? So that brings us to the leading cause of cancer deaths. For male and female, that is both lung cancer. Lung cancer. That is the number one cancer for male and female. Our second one is when we change our and go to our organs, our female and male organs. That's our prostate and our breast cancer. So those are cancers. The third one is still the same for both and is colorectal. So lung cancer, this is male and female. Then our male and female organs, prostate and breast cancer, and then colorectal cancer. And so those are things that we need to know. And those are why we ask when we're assessing a patient about past history and family history, first and second line. Continuing with that, the leading cause of death in adolescents. Now the way that I explain this is basically we have these 16-year-olds who get their license, and that's when they can drive by themselves or they're accident prone. So that brings us to the leading cause of death in adolescence, and that is accidents, multi-vehicle accidents, unintentional injuries. And we all know that with adolescents, that is what we hear and see all the time is a teenager was killed in a crash. So when you get that question, pay close attention to the word adolescent. And that is going to be your multi-vehicle accidents, unintentional accidents. The next thing, which is very sad, is suicide. This is becoming a more epidemic issue with the bullying. So just keep that in mind. Those are the two that they'll focus on because they want us to do the depression scale. We want to make sure they don't have guns in the home, that they wear their safety seat belts. These are why we ask those safety questions when we first see a patient for the first time. Now, moving along, we talk about health promotion and death prevention. What can we do to help these patients that we see, no matter what age? We need to talk about primary. Primary is primary prevention. Just think primary prevention. Things that we can put in place like education, wearing their safety belt, seeing the doctor on a regular basis. Do they have a gun? Does it have a safety lock? Those are things that we can prevent by educating and talking to them in regards to those issues. The secondary is screening. These are our screening things that we do, like the depression scale, prostate exams, CAGE criteria, or the CAGE for alcoholism. Tertiary prevention is treatment. So P for prevention, S for screening, T for treatment. This is Al-Anon. This is doing physical therapy, counseling. Those are things that you're treating. So when you get a question on your exam, and you need to remember that when they give you the examples, are they asking for primary? If they are, what do we know about primary? It's prevention. If they're asking for secondary, we're doing a screening eval. We're doing a screening test. And then for tertiary, we're doing a treatment. For abuse, let's talk about abuse. Now, if you have a spouse come in, they have unexplained injuries, they have a delay in treatment, they have bruises, they won't open up, we need to be thinking spousal abuse. A child comes in, the mother talks for the child, you do a check, they've been at several hospitals, they have unexplained stories. You need to talk to both of them together, and then you need to try and talk to them separately and see what the story is. But with child abuse, they're not going to make eye contact. Those unexplained injuries. It requires a further investigation, and that's when you're going to get your social work involved. And that's our responsibility. So know those two for your exam. Know the differences. Routine screenings. These are the ones that you need to know. So, if you've been in your clinical time, you know that any kind of program that you use, I guess I should say, like I was familiar with AANP. These are your routine screenings they ask you for. You should see them pop up. So cervical screening is not recommended for anyone before the age of 21. We need to remember that. And why is that? Because it's not there yet. There's no statistics to back up that we need to do any kind of cervical screening before the age of 21. Even if they have multiple sex partners. Blood pressure screening. This is one that you may see on your exam. We do start checking blood pressure when the infant or toddler, 3 years old. You just need to know that blood pressure screening will start with a 3-year-old. Anyone who smokes, a one-time thing of screening for a AAA. Now we know that the gold standard for that is an ultrasound. Smoking causes an increase in that, so we need to know that. Also family history, hypertension, any signs and symptoms that the patient complains of, like a pulsatile mass. We need to do our assessment, and then we need to order an ultrasound. But again, this is routine screening that is recommended once in a lifetime for a AAA. Now I'm going to break down each system. We're going to start from the head, and we're going to go all the way through those. This is why it's a 3-hour crash course. We will take everything. You can read this or listen to this over and over as you need to. And we are going to start with the eyes, ears, and nose. So, for example, you have a 46-year-old who comes into the urgent care. She complains of acute onset of severe eye pain, photophobia, which we know that is, she has an issue with light, sensitivity, tearing and blurred vision in one eye, fluorescein stain, confirmed fern-like lines. Fern-like lines, guys, come on, we know ferns used to be associated with keratosis. And I'll break that down for you. So if you have this 46-year-old, she has acute onset of severe pain, photophobia. Look at the descriptive words. Then look at your definitive test. You had a fluorescein stain test that came back, and it's fern-like growths. That is keratosis. It's just what it is. And because this can affect this trigeminal nerve, we have got to get them to an eye doctor because we need to take care of it immediately. Because what can happen? These people can go blind, guys. No, and we don't want anyone going blind. Then we go into your glaucomas. You have your acute angle closure glaucoma, and you have your open glaucoma. Now, open glaucoma are these patients who have had it for quite a while. It's primary, they've been to an eye doctor, they have eye drops, they know probably what the pressures are. But if you have a patient who comes in, and we'll do an example, because I'm trying to use examples in this, because you may see it on your exam. And it's a closure glaucoma. Now just think about that, closure. It's going to be painful. It just closed. Get them out of here. You cannot treat that. Just get them out of there. If they tell you that it just felt like the vision went gone and it was painful, get them out of here. And that's what you're going to choose. You're going to choose send them to the ER. Close the door. So for example, you may have this type of question. Could be a different age. But you have a 62-year-old male comes in, complains of severe eye pain. He's got a headache, nausea and vomiting, halos, decreased vision. You see a mid-dilated pupil on examination. The cornea appears cloudy. That should already be triggering glaucoma, okay? We're going to send him to the ER, guys. We're going to send him to the ER. So that is the only difference between primary glaucoma, which is open. These people know it. It's a gradual thing. Closure is abrupt, painful, change in vision. You're going to get them out. Next, you could see orbital cellulitis. I don't know if you've ever seen a patient like this, but it could be a child, it could be an adolescent. They're notorious for rubbing their eyes. And then what do they get in there? They get infection. If you have an exam question and it talks about a child coming in or an adolescent or even an adult, and they woke up and they have this edema around their eye, guys, that's orbital cellulitis. We're not talking about papilla edema. We'll go into that next. But orbital cellulitis is from an infection under the subcutaneous tissue there, the dermis, and it causes edema. These people will almost be swollen shut. That is orbital cellulitis. Again, what are we worried about? These people, that's intraocular pressure. If this is swollen, you know they're not going to have good vision. And if it is swollen, what's that doing? That's causing pressure on the intraocular nerve. We have got to send them to the ER, guys. When you are dealing with the patients who, in the scenario, it is not something like primary open angle glaucoma or blepharitis, something that we can treat in office, you are going to need to send them to the ER, because that is completely out of our scope and ain't nobody going to lose their vision on us. Which gets us into the next scenario. Let's talk about retinal detachment. This will be just a classic case, irregardless of which leak or if you did Fitzgerald, it doesn't matter. It's going to explain retinal detachment as just like a curtain. It's detached. There's no light going through. So if they talk about like a curtain just came down over their eyes, we are talking about retinal detachment, guys. I actually had an issue with this. I'd had LASIK surgery done about 10 years ago. And not to scare anybody, I'll make it short and sweet because this is a 3-eye crash video. But maybe this scenario will help you. And they do everything, with robotics. And I kept feeling this severe pain, and I was having flashing lights. And I had to go back, and my retinal nerve had actually been a little bit severed from the laser. And that required eye drops and regular visits. But I was at the highest risk for a retinal detachment, which would have left me blind. So that guy's, the optometrist, ophthalmologist, he actually seen me every day. So those people were going to refer to the emergency department because, again, they're not going to lose their vision, guys. Let's move right along and go into our ears. So for exam purposes, you're going to they're going to explain somebody that they have this foul odor to their ear, and you look in and you see this white cauliflower-like mass. Cholestoma, guys. It is it's just casebook classic. Foul smelling. These people probably had infections, reoccurrent, and this is a buildup. But they're going to explain it to a T. White cauliflower, colostroma. We're going to refer those patients, guys. We refer them to ENT. We can't treat that. And you don't want them to get any kind of infection and go into the mastoid bone, which then, can go into the eye. The trigeminal neuralgia can occur. I mean, it's just a basket of complications that can occur. So, of course, we send those patients and get them referred out to an ENT. So now, if you have a case scenario, and we're talking about a peritonsillar abscess. I don't have any tonsils, so I can't actually show you. But if you have a patient who's complaining of a sore throat, and you're doing your assessment, and this patient, you look and the uvula is slid over. It's not lined up. We should already be thinking peritonsillar abscess. Something's moving it over. It's going to be something that we're going to have to require our assessment. They could be complaining of fever, fatigue, trouble swallowing, dysphagia. But what are we worried about with that, guys? We are worried that will continue to swell. And we, of course, don't want to touch it because that infection is just going to come out. But we're worried that they can't swallow. And we have to worry about their airway. So we're going to send that patient to the ER. You can see it on your exam because it's going to be casebook. It's going to explain you're looking at an assessment and the uvula is displaced. We should be looking at an abscess, a peritonsillar abscess to be exact. And again, we should be worried that we're not going to poke and pry around on that because we let infection go and this patient's going to get sicker. And then, of course, like I said, we worry about airway. So we're going to send that patient to the ER. So some of the things that you need to know are normal findings. You're going to have questions that's going to say, all of the following are normal findings. So let's talk about the eye. Except. So, in the eye, it's completely different than our body. Our body, our arteries are bigger than our veins. But in our eyes, our veins are larger than our arteries. So that is when we start looking at doing eye exams, and we have to know a little bit about that. So any abnormal would be if you look in there and you see those wool spots with diabetes, or you see AV nicking. Remember, the veins and arteries cross. And I explained this like two cars are going down the road. They're the same size. So when they go down the road and they're the same size, they stay in their lanes. But if one gets bigger, such as with hypertension, because that's increased pressure, it's making it expand, causing more pressure in there, it can come over and boom, nick us. When those hit, that is called AV nicking. That is when the vein and arteries cross. Now, just a little bit of anatomy for the eye that you may just need to know because they kind of pop up. You can probably do rule of elimination if you have these questions. But cones. The cones, we look for color perceptions. Cones, color perceptions. Rods. This is our night vision. And the way I look at it is, you got those hunters out there and they got to have their night vision, and dogs, they use their rods the most because they can see at night vision. But that is what its purpose is. The macula, that is the central vision. And this is where, if you go have an eye exam, they will check for any kind of issue with your macular. Because it being centralized, like the main area, if it becomes larger, it becomes macular degeneration. And we know that with macular degeneration, it causes like black areas of a picture we're looking at. So if we're looking down the road, in the middle of what we're seeing, we're going to see a black spot. Now, this isn't a white spot because remember, those are scotomas. Black spot. That's the macular. It's the Mac Daddy big black truck. So if you see someone with black spots, like a big black truck, that's the Big Mac. That's the macular degeneration. Okay? And the macular degeneration is abnormal. There's nothing they can do except for try and slow it down. But these people will eventually lose all their central vision. Excuse me. Ears. So we know the normal findings of the ears is we have those 3 big landmarks that you need to know, and that's the incus, malleus, and stapes. So let's talk about the tympanic membrane. We know that the tympanic membrane, it's pearly, it's shiny, we should be able to see through it. It's more or less translucent. Any kind of bulging is fluid, any kind of redness, we need to be worried about pressure. We need to worry about simply with the internal ear is tympanic rupture. So those are the things that we look at for a normal exam. That's what you need to know what they normally look like, and that you should be able to see the 3 landmarks. And if you can't see the 3 landmarks, what does it involve? So we'll go right on into, if you're doing an assessment with someone with their ear and you pull right on this, you know how we do it up and back, then you know that if the pain is already elicited, we need to be looking at otitis externa. And these will just be eardrops, guys. No oral medication. So you can kind of scratch those off on the exam if you see them. Just the eardrops. Now, if you're doing your assessment and you're looking at the ear and you look in and you see bulging, red canal, and they have ear pain, we're looking at externa, and those are media. We're going to be looking for the landmarks. These patients will need an antibiotic orally. So only for externa do we need otitis, or for otitis externa do we need eardrops. So if you have a patient, we're going to move right along to the mouth, and you see leukoplakia, and that is that white spot on their tongue, and it's hairy, and they've brushed it, and they're like, I can't get rid of this area. It does happen with people who don't smoke, but more commonly it does happen with people who do smoke. And we need to rule out cancer. So of course we're going to refer that patient out. So if you see a white hairy spot on a tongue on one of your questions, you should be thinking leukoplakia. And leukoplakia is associated with oral cancer. And we refer those patients out. So in regards to the mouth, people get what's called canker sores or ophthalmos stomatitis. Sounds so foreign, but anyhow, these are painful. Anybody that's had a canker sore knows that they're very painful. This could just be simply gingivitis, guys. You know, we're just going to say, okay, you need to do proper hygiene. We can prescribe magic mouthwash. And if they can't afford that, I've even had patients do swish with hydrogen peroxide, although you don't want them to do it very much. So for exam purposes, you would pick magic mouthwash. And that they'll swish and hold it and then spit it back out. They do not swallow that. In regards to the mouth again, guys, let's go on into a tooth. You could have an exam question that talks about, and they're very, they like to include this one because it can happen. You have you're working in the urgent care and someone comes in and says, oh my gosh, my son was just in a soccer game. He got kicked in the mouth, knocked out his permanent tooth. Excuse me, here it is. So if you have a permanent tooth that they bring in, you need to know that this can be stored in milk, cool milk. And you're going to do that so that it can be reimplanted. And I think that's kind of neat myself. So if you have a scenario where a permanent tooth, now we're not worried about baby teeth, but if you have a permanent tooth that comes out and they have it, you can put it in cold milk. We need to even educate, especially if our patients are young athletes. Hey, you're in soccer, this can happen, so we need to address this. And say, hey, I said work in soccer, I'm sorry. They play, and they could get a tooth knocked out. Now let's talk about salivary glands, guys. We need to know where these are at, just for exam purposes. You have your parotids, submandibular, and then you have your sublingual. We palpate those just to see if there's any kind of infection. If they do, of course, we're going to look at the lymphatic system. We're going to look for mono because we typically see those enlarged with that, and acute infection. So that's basically all you need to know for the salivary glands. And those is that when we palpate those and they're enlarged, that we need to be looking at infection. Tonsils. I know during clinicals I had a lot of strep throat, guys. If these people come in and they have a sore throat and a fever, fever is indicative, we need to be checking them for strep throat. But let's say you have a patient come in complaining of just feeling bad, fever, malaise, fatigued, and having a hard time swallowing, and you look and there's white exudate on their tonsils. We need to be checking these people for mono. Okay, we need to educate them to, and if it comes back, we need to educate them that if they have mono, they're not going to be in school for about 4 weeks. But they have to have an ultrasound come back that their spleen has returned to normal. Why is that? Because if they get hit in that spleen, it can be detrimental. They need to limit their physical activity. And of course, if you have someone come back with mono, you should automatically be ordering an ultrasound. We need to make sure that their spleen is not enlarged. And they can return to sports after an ultrasound comes back. And hint, hint, you may see that on your exam, that it has to require an ultrasound come back that the spleen has returned to normal size. That's when they can return to physical activity and contact sports. Okay, so let's go into, we kind of missed it a little bit on eyes, but these are your abnormal findings. These are papilledema, and the way that I explain this is, guys, the indicative sign is optic disc blurred vision. And think about that. If you have edema, let's just say you have edema in your hands, because mine kind of look that way. But if you have edema in your hands, it looks shiny, but it's not, I can't really see all of the lines in my hands because of the swelling. So it's kind of blurry. This is the same thing with papilledema, guys. They've got swelling around their eyes, not the orbitals, not the cellulitis, but the eyes. So if you have swelling there, of course you're not going to have clear vision, so it's going to be blurry. So when you see on your exam that there is a patient that has, pain, and they're not feeling well, and they're not seeing clearly, and you do your assessment, and the optic disc is swollen with blurred edges. Blurred edges. Now this could be from a multi-vehicle accident too, and we have to worry about that. Why do we need to worry about that? Because listen, if you've got edema in your eyes, that's going to cause pressure here. If it causes pressure here, guys, it's going to cause intracranial pressure, and that is a medical emergency. So these people with papilledema may not have it in the beginning with a multi-vehicle accident, but they will have it or show it or could show signs of it later on. So that's why we watch people that have a head injury, and that's why we check their pupils reaction. Because if they start becoming sluggish, we need to worry about edema around the eyes. We need to worry about that edema going to the head and causing intracranial pressure. So it just kind of goes hands in hand. If you dissect each question, you should be able to associate it. Well, okay, the eyes are swollen. Well, yeah, the eyes are swollen, and you need to worry about that pressure and that swelling going up to the head. So if you have a patient with papilledema, you need to be worried about intracranial pressure. If you have someone that you're doing an eye exam on, and you see retinal hemorrhages. Now let's think about that. These are like little red dots, guys. And it's basically just little bleeding. This is high blood pressure. These people, or pressure, sometimes you see this, you know, like if someone says, I've been coughing my head off, and they come in and they have like a busted blood vessel. That's because that pressure's increased. But if that pressure stays that way, then you're going to look and you can see the nicking, the AV nicking, and you need to associate both of those with hypertension, guys. So retinal hemorrhages, if they're just sick, it's okay. It's going to resolve because they've coughed and they've caused that pressure. But if they continue to stay and accompanied with AV nicking, we need to look at hypertension. And, you know, that's been there for a while, guys, because at the point that hypertension involves the eyes, which is retinopathy, they've had it for a while where it's been uncontrolled, non-compliant, or maybe they just don't go to the doctor. But these are the Latin phases. When you start seeing issues that change the eye, you need to be looking at a long-term issue. So that is why we send these people regularly for hypertension and diabetes to the eye doctor and foot doctor, foot doctor for diabetes. But because their eyes can change, and we know that even with hardening of the arteries as they get older, we need to worry about these copper and silver arterioles that can pop up in the eyes. Again, you could see these with high blood pressure. Why? It's been there for a while. And maybe it's uncontrolled. I mean, if we control the hypertension for a patient, then you shouldn't be seeing these long-term issues in their eyes. You can if it's been there for a while, and you can if they're elderly and they've been under hypertension. But if you do your assessment and you see AV nicking, and you see copper and silver arterioles, or you see little retinal hemorrhages, we need to be looking at increased pressure. What causes that? Well, the blood pressure is higher. Okay, so let's look. Do they have a past medical history of hypertension? No, then we need to do a full workup. If they do, is it controlled? We need to be checking their BP logs. We need to be looking at these patients and saying, hey, how's your blood pressure running? And if they're not checking their blood pressure, check it in the office. If it's high, we need to have a repeat on a different day. Or you can wait, a little while if they want to sit around, see 2 consecutive. But it's better to have it on separate days because some people do suffer from white coat syndrome, so that's why it's better to have them check at home and then check in the office. That's regarding blood pressure, which we'll get into more of that when we hit the actual cardiac section. So those are some of the eye exam issues that you're going to see. And when you do see that, come on, guys, we got to be thinking, hypertension with these issues, or if we see the cotton wool spots and those little white areas, that's diabetes. If you have a patient who is constantly falling, and they probably won't tell you that their eyesight's changed, but we need to be looking and see if they have cataracts, because cataracts have been linked to falls as well as blood pressure. So that's why and we'll get into that later on, why the JN8 guidelines have increased for the elderly, simply because, they're higher risk for osteoporosis because of a multi-system thing. The JN8 guidelines increase because of the falls. And these people are smaller. Their metabolism, everything's slower. They cannot tolerate a low blood pressure because then they just fall. And we know with falls causes fractures because of osteoporosis. And we'll get into the geriatric site separately, and we'll go over each individual thing. So, again, if you have a patient who is falling and probably like a middle-aged person, older gentleman, maybe has hypertension and diabetes, let's look at cataracts. Let's have them go see an eye exam, go have an eye exam. Excuse me, sorry guys. If a patient is having trouble breathing when they come into you and they've actually been just one side of their nose, and this is if it's an exam purpose, and they're having trouble breathing, let's look up in that nose. We should be looking up in that nose. But one of the reasons that we do that is because sometimes if they complain of snoring or just one side is causing them issues, they can have an obstruction or a polyp. So if you look and you see a polyp or you see some obstruction, there's nothing that we can do, guys. We need to refer them to an ENT, okay? So remember, one-sided, usually it's not both-sided, very rarely, but if they have one-sided and we do our assessment and we see a polyp, we need to refer. So let's talk a little bit about vision. Some of the things you need to know, we've kind of already talked about scotomas, and those are scotomas, however you want to say it. Those are the white spots, guys. These are kind of like a white blurred area. And we usually, do our assessment with the Snellen chart, and we get their, vision. We do visual fields of confrontation when we're looking for their peripheral vision. And if they talk about blind spots, have them explain to you what they see. And this is like a blind spot. It's not going to be the black, because remember, that's just the whole picture's gone. That's macular. Big Mac truck, black truck. Scotomas are a blurred white area, and they'll look, and they can almost kind of see it behind, but it's all blurry, and it's just one spot. Those are things that we need to worry about with scotomas. Again, we are going to refer these people out. Now, another thing we need to discuss when we're doing eye examinations, and what is the test that we do for color blindness? We do have more people coming in that are colorblind. So we do the Ishihara chart, and you'll need to know that. Most people probably already do because they did it in their clinicals, but just remember, for color blindness, that's the test that we use. And that's the one where you open the book and it's like two different colors. It's like green and orange, and it'll be a 6, and they'll have to be able to see it. We also need to know, what is the age? At what age do we see patients, out of all age groups, at what age, well, let's just go back, sorry. At what age should we see a child have a 20/20 vision? And that's at age 6. So at age 6, the visual acuity in their eyes should be 20/20. If it is not, we need to refer those patients out. So just remember, age 6, 20/20. So let's talk about hearing. Let's talk about the Weber and Rhine test. Okay, guys. So you have a patient that comes in and they're complaining of ear pain. Now, the best way to remember this is they're opposite of each other. Okay, so let's say you do your well, let's go back. The Weber test. You're using the tuning fork. You're sticking it up here, and you flick it, and they only hear it in one side. Now listen, a normal exam, guys, would be it lateralizes to both ears. So basically, they do this. We do the tuning fork, and they'll say, "Oh, I hear it in both ears." Okay, then there's no hearing issue. There's no infection we need to look for. It's a normal exam. Normal exam. If you do a Weber test and it lateralizes to the, let's say the right ear, but you're seeing the left, but the right ear, then the right ear is affected. It should not lateralize. A normal exam will not lateralize, but if it does, it is abnormal. A Rhine test, we do the tuning fork back here. You need to know the mastoid process, guys. This is the mastoid process. We need to know that we put it on the mastoid process and that we compare bone conduction to air conduction. So for the Weber test, it's BC greater than AC. Remember, bone. For the Rhine test, we are looking and doing the mastoid and doing it to the air, and seeing how long they hear it in the air. So if the Rhine test and they hear it more so on the bone side, and BC is greater than AC. So I actually just wrote this down on my scrap paper. Okay, guys, we should be hearing on a Rhine test, AC is greater than BC. If you remember how we did our, well, not everybody did it, but we had to do a full body assessment for our grad school. You know that they should hear the sound in the air longer than on the bone. Why is that? Because the bone's thicker. It's harder to get through the bone. So a normal exam would be air conduction is greater than bone conduction. Okay? All right, guys. Conductive hearing loss. These are things that is like earwax, headphones, anything that is in the ear that is stopping the sound from going in. And we can correct that. We can see earwax. We can remove earwax. We can say, hey, kids, take your headphones out. You might hear me. That type thing. Sensory neural is like your Meniere's disease. It's your people who also have presbycusis, which is a normal aging for hearing loss for the elderly. And you'll need to know that. So what do we see? We see these little old people if you're in a nursing home or you're in a hospital and the TV is sky high. Well, they have presbycusis. Sorry about that. And that is sensory neural. We can't change that, guys. That is normal aging for the elderly. That's why they turn the TV up loud. Hint, hint. But also like Meniere's disease. My brother suffers from Meniere's disease. That's sensory neural. That is why the only treatment for that when it's extreme is to take out the labyrinth, and then they lose all their hearing. So just remember that conductive is something that's just blocking the sound waves from going in. Sensory neural is kind of inside. It's something we can't change. We can treat the symptoms, but that's about it. Presbycusis, though, that's a normal aging. I mean, we'll get into that with geriatrics, but just know that if you suspect an elderly patient has presbycusis, they're going to have the TV up loud. All right, guys, so let's talk about eyes. Let's talk about things that we can treat with the eyes. So I'm going to kind of give you an example. A 23-year-old female, cute, she's going to have a swollen red warm abscess on the lower lid. Warm abscess on the lower lid. It's going to be a hair follicle. What do we already know what that is, guys? If you have a hair follicle and it's swollen and it's red and it's an abscess, we need to be looking at hordeolum. You have to be able to differentiate, and we'll go through all that. You treat this. How do we treat this? We treat this with warm compresses, right? Okay, so we're going to follow up, have them see an the ophthalmologist, but we're also going to just tell them, hey, warm compresses, it'll take down the swelling 2 to 3 times a day. And then I just totally lost my train of thought. I'm sorry, guys. But with the hordeolum, if it continues to come back, then they need to be seen by an ophthalmologist. Okay, guys, Tigerium. This is a yellow triangular thickening on the conjunctive. I've shared videos and pictures. This is yellow. It comes across as yellow. It just comes right across. That's a Tigerium. You need to know that. Allergic rhinitis. What do we know that as? These are people who have seasonal allergies, guys. It's usually around ragweed, it's hay fever, and you know, we kind of went into that about you can use nasal sprays, but you need to know that with nasal sprays, typically the one we use is Afrin. We try not to, but you have to be very careful with this when these patients are talking about coming back and, oh, I felt better and now I'm not. Well, how long did you use the nasal spray for? Oh, I used it for 3 days. No, you probably didn't. You continue to use it because you've got medicamentosa. You need to know that medical term. That is rebound rhinitis, medicamentosa. Nosebleeds. You got a patient came in, he's got a nosebleed, guys. Where is the most common place that these nosebleeds occur? That's a Kesselbach's plexus. It will be probably a scenario, and it's going to tell you that where is the main injury at. You need to know that. If you see a patient who has nosebleed, you know, you can hold pressure on it. And if the bleeding won't stop, which you kind of should have already known this during your assessment, but if the bleeding won't stop, look up in their nose, look at their nasal palate, look at the palate of their mouth, because these people probably will either have a complete like through and through hole from cocaine abuse. You will see a questionnaire exam that's going to talk about illegal drug use. If you have a nosebleed that will not stop and you look up in there, you may see the nasal septum is deviated with a hole, or it could just be completely gone. The hard palate might have a hole through it. That is from chronic illegal drug abuse, which is normally cocaine. If you have a patient comes in with strep throat, well, let's say they come in and they complain of a sore throat. They may have a fever. Just don't feel good. Don't want to eat anything. You do a rapid antigen strep test. You know, I did so many of those. Swab it. We can do a rapid strep test, and it comes back positive. How do we treat that? We treat that with our penicillins, guys. Moxicillins is an alternative, but let's say that they've been on it and they say it never works. We can also do azithromycin and Z-Pak, because you'll have those patients that'll come in and say, oh, I've taken penicillin all my life and it doesn't work. Well, okay, you can give them azithromycin, no big deal. But the main thing is that you need to remember that we have to recheck these patients. We need to do a test of cure. In my practice, it was point of care. You may say point of care, or you may say test of cure on your exam, and that's repeated. And you want to do that about a week after you finish the antibiotic, because one, you got to make sure the antibiotic's out of the system, because it'll just kind of mask it. And you want to also make sure that they don't go around and just give this away, you know, give it to somebody else. We don't need any epidemics. You also can talk to them about saltwater gargles. It's really good. Tell them to drink fluids, Tylenol or ibuprofen for the pain, depending on the age. They can use cough drops or throat lozenges. But the main thing that we need to know is that we can do the RADT, which is the rapid antigen test and that detection test, and it tells us within minutes if they have strep. And also, you may see, not for exam, but out in practice, you may see that some of the policies do state that if it's a positive throat swab, that you send that for a culture in CNS. But for exam purposes, you'll just need to know that it's a rapid antigen detection test, RADT. Now, if a patient comes in and they have fever, fatigue, trouble swallowing, again, don't want to eat, and you look and they have a strawberry tongue, okay, that we know already differentials with the strawberry tongue. We're looking at B12, scarlatina, but let's say they also have a sandpaper rash. This will be a case scenario, guys. They're going to present it to you in some kind of case scenario, and you're going to see a fever, sandpaper rash, strawberry tongue. That's 3 S's. Scarlet fever, strawberry tongue, sandpaper rash, scarlatina. You've got to dissect it out. They could also have some peeling of the hands and stuff. The skin peels. Let's move right along. We talked about the treatment for externa and in media. You will see those. So let's go into dermatology. Let's talk about the skin issues you're going to see on this exam that you need to be able to understand and know when you see it. So on the exam, if you have a patient who comes in, and it's going to be someone they're going to say has been traveling or hiking, they like that word, hiking. We should already be worried about a tick bite or some kind of injury. That should already be getting your mind thinking. And then they go into talking about a week afterwards, they started getting a fever and they've got this rash and they don't feel good. Guys, sorry, my nose is itching. This is something that we need to be looking. If they have a rash and they've been hiking and there's no bullseye, we are looking at Rocky Mountain spotted fever. If they describe this person and they tell you in the case scenario that it has a bullseye rash, then you are looking at Lyme disease, erythema migrans. You need to know that. But the thing about it is both of their treatments is doxycycline. So, again, look at your case scenario. Look at your rash. What kind of rash is it? Is it a macular-papular rash? And does it have a bullseye rash? If there is no bullseye and they have been hiking and they've got a sudden onset of fever and it's been about 2 weeks, well, let's say 10 days to 2 weeks, you are looking at Rocky Mountain spotted fever. So just dissect those. Look for your descriptive words. Impetigo, guys. This is impetigo, honey-crusted lesions. My son gets this, and I know I've talked about it before, so we'll talk about it again. My son gets this. Okay, impetigo. These are little lesions that come up honey-collared. They're honey-collared. It is the only ones that are honey-collared, I assure you. But they're going to be cluster, and sometimes they can run up into their nose. This is actually like off of staph. And once they get impetigo, they're high risk for it. Every time their immune system gets low, anytime that they are stressed, And it's not just like one blister. They're little blisters. And the treatment for impetigo, honeycrusted lesions, is mupirocin cream. Koplik spots, guys. You're going to see this with rubeola. Rubeola, we know, has been coming back a little bit, mainly because some people do not get their vaccinations. But these people are going to have a rash. They're going to have these little spots in their mouth, mainly under the tongue, sides of their mouth. And those are referred to as Koplik spots. If you see that word in your case scenario, you need to be thinking rubeola. These people, we need to educate on vaccinations. We need to start treatment for it. It's going to be just a classic case book of Koplik spots. It doesn't matter what they include in that. If you see the word Koplik spots, I assure you it's rubeola. Now, let's go into a case scenario where you have a mother brings in a child, and she's talking about her daughter wakes up in the morning and she has all these scratches on her hands because she says she itches so bad at night. She doesn't see it very much during the day, but she says at night she just digs at herself. And we look, and we're doing our assessment, and we look through the webs of the fingers, and we see burrows, guys, burrows. Burrows is your key word. Scabies burrow. They burrow. They come out at night. That is why we like to do the test. Well, we can just diagnose it from assessment, but we like to do any kind of scratch test in the morning. They will come out at night, and they like to get, like I said, in the webs of the fingers. And we need to make sure that the mom knows to wash this stuff in hot water, very hot water. We need to treat everybody in close contact with promethazine cream. We need to make sure that, they follow all of this and they do a follow-up, because we don't want an outbreak. And it is contagious. That's why we treat everybody that is in close proximity or has been in close proximity to the patient himself. So if they're out of school, we have to notify them that someone had scabies, and so they can do their assessment. In a nursing home, we have to go through with anybody that had contact. If we have a geriatric patient come in, we need to look at them. We need to treat the roommate, their roommate in the nursing home. And we need to let the medical staff know. And this is why, because it can go on rampant. You can just pass it from person to person, so they have to be treated. So if you have another patient who comes in and they have, let's say they have this round area, multiple of them, and they have a white plug. You should be looking, you should associate, because it's the only one with a white plug, is molluscum. We need to worry about this if we see it on babies, guys. If we see it on babies' genital areas, we need to know that that is a sign of sexual abuse. It is very contagious. It is direct contact. So, seeing it in older people who are sexually active, we treat them. But seeing this in a child should automatically be like somebody's in trouble, because and I should emphasize a child's genitalia area, because we know that that means they've been unfortunately probably sexually abused, because it is made from contact to contact. And you need to notify, when you come to that, social services. They are the ones who follow up. We need to get people involved. So let's talk about melanoma, guys. So melanoma is going to be your classic case on there. And again, it's going to be in a case scenario if they have it on the board. And it's going to talk about irregular borders. It's basically going to give you a case scenario, and I'll just make one up. A 54-year-old comes in and he's there for a well check visit. You are doing your assessment because he has had history of other issues, and you note that on his back, it could be in his face or his head if he's bald because there are sun-exposed areas. And you note on your assessment that there is a mole, and it is irregularly bordered. It's kind of jagged around, and it's dark and it's light. So it's got different colors, and it's gotten to about the size of a 6 mm. So we need to worry about that this guy, especially if it's in sun exposed areas and it's got irregular borders and it's got different colors. We need to be worried about melanoma, guys, because this is it is your textbook melanoma case, and we need to send these people to a dermatologist. We do not do the biopsy. The reason that we don't do the biopsy is if we suspect cancer, they are going to have the testing done that actually, sometimes they're just one day. And what they do is they basically take a biopsy, a pinch biopsy, and then they'll take excisional. And then they'll go on further out until they reach an area that comes back that it doesn't have cancer. So that's how they do the staging and stuff. So that's completely out of our scope. So if you have somebody who comes with an area on their, no matter where, and you're suspecting melanoma, we refer them out, guys. A skin tag, yeah, we can take that off. An area that they don't like, we can biopsy it. But if you're thinking that is cancer, we do not. We refer them out. Anything on the face, though, guys, that's out of our scope. Nothing on the face. Nothing on the face. It goes straight to a dermatologist. Basal cell carcinoma. Basal cell is, you're going to see it. It's going to be around here. It's going to be on the face, sun-exposed areas, and it's indurated or atrophied. And we know what that means. Indurated and atrophy, you should be looking at that. When you get a case scenario and it talks about it in a place on someone's face or their back or their head, because bald people have sun-exposed head areas, and it talks about being atrophied, which means the skin's gone or it's shriveled up. Excuse me, or it's indurated. It's a dip. Skin's missing and it's shiny. That is your basal cell carcinoma. And we need to refer those patients out. It's not something we can treat. But you do need to know that basal cell carcinoma is a precursor for melanoma. You do need to know what it looks like, because whether you're taking the ANCC or whether you're taking the AANP, on the ANCC, you're going to have to pick the picture. So that's why it's very important to kind of review the slideshow and the pictures that I have, simply because that is what you may see on your exam for the ANCC. For the AANP, they're going to explain it pearly, waxy, indurated, shiny. It's going to be in a sun-exposed area. And you need to associate that with basal cell carcinoma. Now, actinic keratosis. This is a precursor to basal cell. And it is something that comes up. It could be gradual. However, I'll be first to tell you that mine came up overnight. I had one right here. It actually is coming back. I don't even know if I can get up close enough. Oh, you can see it right in there. And I'll have to go have it off again, which they did cryotherapy for me. But you need to know for exam purposes that we treat that with 5-FU cream. And it's a hard area that comes up. And it's pointy and it's itchy. And when I scratch it, it hurts underneath. It almost made me feel like I had like roots. But we do not prescribe 5-FU cream and cryotherapy, and so we would refer those patients to dermatology because actinic keratosis comes up on the face, guys. So again, we don't touch it. But you do need to know that it can be treated with cryotherapy and 5-FU cream. Again, for board purposes, you need to pick 5-FU cream, and I don't believe they have both of them on those. But that is the treatment for actinic keratosis. And if you see somebody with that and they're like, it just came up, or it's been growing and it's hard and it itches, it's about the only one that itches, really. So if you see itching, you should be thinking actinic keratosis. So some bungal hematoma. Let's talk about that, guys. This is someone who comes in and they have, sorry, I didn't mean to scratch, but they'll have blood trapped underneath the nail bed. A lot of times you see that with somebody who got hit with a hammer and there's blood trapped, but it's increasing. And the blood has nowhere to go. We have got to drill a hole and drain that blood. You'll need to know that for your exam. Because they're going to ask you, how do you treat it? And we can drill a hole. You can use like a little needle, paper clip, of course you want something sterile, and release that pressure. So going on to our skin lesions, let's talk about acanthosis nigrans. This is that velvety. It's under the armpits. It could be on the belly. Lots of times you see it on the back of the neck. And again, I've said this. This is how I associate it. It is one of those where you look and say, "Gosh, has this person even bathed for a while? Because that looks just like crud." Well, don't necessarily think these people haven't bathed, because if you see these issues, this scenario, and it's velvety, and they may say trunk area or axillary, or they may say breast, and it's velvety, we need to be thinking about acanthosis nigrans. And what do we see that with? We see that with diabetes, people. This is associated directly with diabetes. So if you see that on your patient, you can always just rule it out easily. Just kind of get a washcloth and wipe it off. And if it's not crud, then we need to be doing some testing for diabetes. Psoriasis. Now, psoriasis, I don't see where there's silver, but hey, they're going to say fine, silvery, white scales. I think of fish. I don't know why, but I think of fish when I see that. But fine, silvery, white scales. They have pitted edema, or pitted nails. Pitted. They have, they may even say, they may even come in and say, I have these lesions, and they're going to look scaly. I don't think psoriatic lesions look silvery, but hey, I remembered it that way for the exam. I'm like, I don't see no silver. I just see rough skin. But again, if you rub the scales backwards on a fish, they might be that way. So, but a fine silvery white scales. And these people could have several layers. Lots of times it's on the elbows. My brother gets it around the hairline. You can have it on the knees. And in one extreme case, I actually had a patient who had psoriatic lesions over her entire body. These people, it hurt her so bad. I had to do treatment on her legs because there were these major areas. And I mean, we did Xeroform with it, but you don't need to know that for the exam. But for psoriatic lesions, it's autoimmune. These people, excuse me. So with these psoriatic lesions, you need to know two different distinctive things with psoriasis. So someone with psoriasis could have where the lesions are removed, whether it's trauma or just the dermatologist removed them. But where the old lesions were and new ones form, that's called Kubner phenomenon. You need to know that. that is new lesions or plaques, however you want to refer to it as, but they go back where the old ones were. And that's kind of where it should get you to, this is autoimmune, and we treat the symptoms, but we don't have a cure for it yet, guys. We do methotrexate, but it can turn into psoriatic arthritis, which involves the joints and is very painful. So with the Kubner phenomena, let's say that the lesions were removed and new ones formed, and then they're like, oh, I started having this bleeding. These are pinpoint bleeding in the lesions. This is Utzbit's sign, guys. You're going to need to know this. It's going to be just a sign that when you see that it's psoriatic lesions and that it's bleeding, that's called Utzbit's sign. Psoriatic lesions that, again, involve the joints, we need to be looking at psoriatic arthritis. These people need to be referred to rheumatology because they're probably going to be on methotrexate. And again, there is absolutely no cure for it. We treat, they typically just treat the symptoms and follow up with rheumatology. Erysipelas. Erysipelas is a form of cellulitis, and it's basically just one lesion. It could just come up. It's very fragile. You touch it, and it just bursts. Now, with cellulitis, there's redness, there's induration, there's multiple lesions. These are people that have peripheral artery disease, and they basically. It's a chronic thing. You'll see these people come in and out with cellulitis. But with erysipelas, it's one. It is just like one large, hot, indurated skin lesion. We're not talking about a hot, like a warm place under the skin where we would be ruling out DVT. We're talking about an induration that is one single blister. And that's basically erysipelas. And we know that that is caused by group A strep. With cellulitis, just pure cellulitis, that is usually staph. But this is group A strep for erysipelas. And it's, like I said, it's going to be one big lesion with a hot red area around it. You're just going to see one. And typically, anytime that we're dealing with skin lesions that can cause problems, we are looking at doxycycline, which gets us into the next issue. You have a patient come in and they have a dog or a cat bite, irregardless of if the animals had the records or not, their shot records. We still need to treat that. We need to clean the wound. We need to provide amoxicillin. And if they haven't had a tetanus shot in the last 5 years, remember, if we're talking about anything that has to do with an infection that can go to osteomyelitis, especially with, in the limbs, that we need to be treating this. And that's why we want to give them a tetanus. Simply because we don't want any issues. We got to treat the wound. We got to give them antibiotics, which again, amoxicillin. If they have a penicillin allergy, we're going to give them doxycycline. So mainly you're going to have a question, and it's going to reflect around a tetanus booster within 5 years. And it's also probably going to tell you what is the treatment, which is as your doxycycline, because that's typically what we prescribe for that. You can give the Augmentin times 10 days, but for the most, we like to do the doxycycline. So let's talk about someone who comes in and they have a ring-like lesion. Now, we should all know this. And we're all going to say ringworm. But you have to know for the board purposes, this is Tinea corporis. Tinea corporis. This is treated with an antifungal. So any antifungal that you see that ends with AZLE is how we treat it. Now let's say that you have a young individual come in and they have acne on their face. And we know that is basically around when they're going through hormonal changes, your adolescence, and you could have some, older patients going through it as they go through menopause and changes in estrogen. But you need to know the stages of treatment for exam purposes. So, if you have a patient come in and they have acne, of course we're going to tell them to wash their face if it's mild, and they can try over-the-counter things. But let's say that they come in and they have tried everything over the counter. I've tried everything, Noxema, hydrogen peroxide. We are going to tell them that we're going to treat it with Retin A. Now, if the patient comes back and they're like, well, we need to warn them that with Retin A, we do know that it's going to cause some peeling. That's to be expected. But, however, if there's excessive drying and it's under control, key word, is the patient coming back and saying, hey, my acne is better, but it's really dry. It's peeling a lot. We can not stop it. We don't want to stop it, but we can back off to every other day. But if the patient comes in, they've tried over the counter, you've had them on Retin A, they come in, they're worse. You see, there's more acne. It's not, and it's dry. Okay, so at this point, we're going to add tetracycline. This is an antibiotic, the only antibiotic that we like to add, and that's to help with the skin and the oils and the infections, to help kind of like an additive. But again, if that patient comes back, you have tried OTC, you've added Retin A, you have added tetracycline, and they are still not any better. We've done all we can do. That patient's going to have to be referred out to dermatology. And so that's basically where we're at. You just need to know that for exam purposes, that if you have a scenario that says that the patient has tried OTC and you've had them on Retin A, then you need to add tetracycline. If they come back in and you've had OTC and Retin A and it is controlled, it's better, there's less lesions, but it's excessive drying, then you can decrease it to every other day. But you want to make sure you do not stop it. So let's go into rosacea. Now, I don't know if anyone's been familiar with this, but I had a friend who had rosacea, and they were pale colored. You see it a lot with Celtic background. Those are those real pale colored people. Although he wasn't Celtic background, but they have the little rosy cheeks right here. And you can see like little spidery things in them. This can be treated with Metrogel. A lot of times you'll see people, especially if it's males, they're very inferior of it. My friend was a male, and he wanted to cover it up. Now we can just do some Metrogel, and that can keep it at bay. But you'll need to explain to them about washing their face and not letting it get excessively dried out, and to use the Metrogel. Now brings us to cardiac. Okay, guys. Well, one more thing I want to include for dermatology is if you have a burn, if you have a patient who comes in with a burn and there are no blisters, it's just red, that is stage 1. If you have a patient who comes in with a burn and it has blistering, then you're looking at stage 2. And anything less than that is down into the dermis or the subcutaneous tissue, and we are going to look at that patient being hospitalized, because we are going to look at some issues regarding the burn going further in. But for a patient who has a burn that can be treated, we use Silvadene. You'll need to know that, Silvadene. You need to know the rule of nines. So the easiest way to remember that is basically 9 and 18. Your longer limbs are your nines, your arms and legs. And then of course your trunk and your back, which is a bigger surface area, is your 18s. Now, for a child, it's not necessarily half of that, but it's going to be less than that. I believe we decreased that by 4. It's just simply instead of 9, we're looking at 5 or 6 percentage-wise. You're going to have one burn question, and you're just going to have to add it up. If it's an arm and it's a leg, and it's an adult, we know that that is, 9 and 9. That's 18%. One arm, one leg, 9 and 9. So just kind of, just know your rule of nines. It's just something that you kind of have to look at. It's not really that hard. You should be able to figure it out, just simply because it's one question. Don't beat yourself up about it, but just know what your extremities are 9s, your trunks are 18. Actually, just to correct that real fast, if you have a question that in regards to a burn to the arm and top of the leg, so the whole arm is 9. Each side is 4.5%. The leg itself is 18 on each side. So that's what you need to, our arms are shorter than our legs. So, and they're smaller. So just remember, if the leg is 18, the arm is going to be 9, which is 4.5 on the front and 4.5 on the back. So if you just have the top part, that's 4.5. And if it talks about the leg, you're looking at 18 around the leg. Okay. And I would just review rule of nines. People learn differently with it. But you're going to have one question regarding the rule of nines, so just know it. So let's go into cardiac. Okay, this is my favorite one, and it is easier for me because we need to know a little bit about the heart. So for several questions you're going to have on your exam is going to be regarding murmurs, locations, and the first thing you need to know is, and you can put this on your scrap paper if you want, but you need to know like what the landmarks. So I'm going to use my little board here, guys. Excuse me. And you can count this like as your paper, but let's just draw a heart, okay? I know, not so good, but, and so this is Alex. These are apical area. And this is Tom. Yeah, he just hangs out there, This is Matt. He's pretty important. And then we have Paul. So do your little mnemonic. This is mitral, tricuspid, pulmonic, and aortic. You can do it the way you want. But the easiest way to remember this is Alex is closest to the right side of the neck. And they're going to say that on the exam. Sorry, guys. Right side of the neck, okay? So you might want to draw your mnemonic and put right and left, okay? Because they're going to ask you which area radiates to the right side of the neck. Right side of the neck. Oh, that's Alex. Okay, A. you've already answered a question. It's very simple. Mat. This is our mitral area, guys. This, you need to know, where is this? This is the 5th intercostal space, mid-clavicular line. That is the location. This little doohickey, for exam, is going to say which radiates to the left axilla. Okay, we know Alex can't come clear over to the left side. That sound will not be radiated there. But Matt, he can radiate upward. Yeah, that sound can go up there to the axilla, okay? They're going to tell you on your exam if it's the right or left side. All right? So, the mitral is at the 5th intercostal space, mid-clavicular line. Know that. This is also where you're going to hear the S3 sound, okay? S3 sound is in CHF and pregnancy. Now, you'll need to know that simply because it's going to ask you, where are you going to hear an S3 sound? CHF, pregnant patient, 5th intercostal space, mid-clavicular line. There you go. Okay, so let's do a scenario, okay? So all of you guys may use something different. I use Mr. Pass, Ms. Ard, okay? And I only put the P in here for physiological murmur, okay? So this is your systolic. And how do we know that? Sorry, kind of went blank there. Okay, so let's start back over. Let me see if I can correct this. Okay, so let's try this again. So, we ended up with Mr. Pass and Mrs. Ard. Mr. Pass, MVP, okay? Now, all you need to know is Mr. Pass, this is systolic, okay? Systolic, Mr. Pass, MVP. Mrs. Ard, this is your diastolic. On your exam, they are going to tell you if it's a systolic and where it radiates. Pay attention to what kind of murmur they're telling you, because you can narrow it down. If they tell you systolic and you know that's Mr. Pass MVP, remember, mitral valve prolapse is also called mitral regurgitation. So they may interchange that. Do not be alarmed. Just know that mitral regurgitation is also mitral valve prolapse. But if they say systolic murmur, look at your answers. Look at the answers they give you. And they typically pick aortic stenosis. This, your S, systolic, okay? That's what pass is. The S is systolic. I was saying P, and that was throwing me all off. So, anyhow, so if they say it's a systolic murmur that you hear, mitral regurgitation, brain fart, sorry guys. But look at this, aortic stenosis, okay? This is physiological murmur. P is physiological. Aortic stenosis. If they say diastolic, mitral stenosis. Look at your mnemonic, okay? In case you guys need to see that. And you can practice this. I put this on there. You also need to know that Paul, he's at the center, a 2nd intercostal space, okay? So, pulmonic, you'll need to know location. We went over mitral. That's your 5th intercostal space, mid-clavicular line. It's your S3 sound. That's where you hear it in your CHF patients and your pregnancy patients. Okay? So just read your question very carefully. If they say right side of neck, even if you get confused, visualize right side of neck. What is on the right side? Look. Okay? And down here, they can't radiate all the way up. You leave yourself with aortic. Okay? Now, they're going to say left axilla. Mitral. That's probably not even going to be in there, but you need to know that the mitral valve radiates up to the axilla. Okay? You also need to know that the PMI, and we should know this because we learned it in grad school, the PMI or apex is at the mitral area. That's all you basically need to know for heart murmurs and cardiac, guys. That's it. Just practice it. Know your landmarks. Know what they are. Know Mr. Pass MVP. Know that that's systolic. Read systolic murmur in there. If you see systolic murmur, look at your mnemonic. You can do rule of elimination, then look at your area. It's really that simple. Okay, so one of the other questions I like to ask is, what makes the S2 sound? It's a very simple question. You're going to fly right through. But an S2 sound, that is our semilunar valves closing. Let me go ahead and put this down. It's our semilunar valves closing. Okay? It's very popular for them to ask that on the exam. Now, let's go into cardiac. All right. So, what do we know you're not going to have for the AANP? You're not going to have any pictures. You're not going to have any EKG strips. You will have that on ANCC. But for the AANP, and even for the ANCC, they want to know that you know what, what atrial fib is on a EKG. So that is no P waves. They're going to tell you that in a case scenario. On AANP, you're going to have, it's going to be casebook of critical thinking. An elderly patient comes in. You've recently started her on thyroid medicine. And she comes in with heart palpitations, shortness of breath, diaphoretic, and you put her on an EKG, and you note on the EKG there are no P waves, and the heart rate's like 120. You should already be looking at AFib with RBR. Now, I do have cardiac experience, so I do know how to read those EKG strips. But it's as simple as that. If you do not have, it's PQRS, ST elevation is always MI, ST depletion is an old MI. Those are the only two you'll need to know there, because it may say that you have a patient coming in with chest pain, shortness of breath, numbness. EKG would show what? And it would be an ST elevation, or what they refer to sometimes as tombstone. But just know that your ST segment is elevated. For atrial fibrillation, there are no P waves. You have QRS, and then you have your T. The reason being is that with AFib, there are two different areas in the heart that are fighting for the SA node. So we just have the SA node that fires, and that's how we get our P wave, and it gets our heart in regular rhythm. But when you have an extra SA node in there, or an electrical impulse is what we typically call it, they fight against each other, and sometimes they're just absent because you don't know where it's going to be. So that is when you need to look at AFib, atrial flutter, atrial fibrillation, with RVR if it's greater than 110. So if you aren't familiar with that, I suggest you go on YouTube and just look at some of the EKG strips for atrial fibrillation. Again, for the ANCC, you'll see it on there. For the AANP, it will be in descriptive form. Now, one of the things that you need to know is that murmurs come in grades, okay? We've got 6 grades, and it'll say like grade 3 of 6. So at grade 3 of 6, it's loud. It isn't until, and this is the one you really need to focus on, grade 4 of 6. Grade 4 of 6 is when it's loud with a palpable thrill, meaning you can feel it. That's a murmur. We're talking about murmurs now. You can feel it. That's a thrill. And then you need to know 5 of 6. Okay, so this 5 of 6 is when it can be heard with the stethoscope partially off the chest. So you can look at murmur grades. There's grade 1 through 6. No, grade 4 is when you can hear it and there is a thrill. Let's go into what can cause atrial fibrillation. We need to know that hyperthyroidism, electrolyte imbalance, acute renal failure, and infection can throw someone into atrial fibrillation. So if you have a new patient that comes in and it's a new onset of AFib, and you're going to know because if they've had AFib in the past, these people are going to be on Eliquis, or they're going to be on amiodarone, or they're going to be on Coumadin. They're going to be getting, if they're on Coumadin, they're going to be getting INRs with a target range of 2 to 3. Hint, hint, you need to know that for your board. And if their INR is, say 4, you're just going to hold it for a day and resume. But if it is elevated, which means that they're thinning, let's say that their INR is, remember we want 2 to 3. So let's say their INR is 5, so that means it's pretty high. We're going to hold it, and then we're going to decrease the dose by 1. If it is low, you may have to get an extra dose. But they want to know that if you draw an INR on a patient and it is elevated, that you're going to hold that dose. You may have to decrease it as well. If it is greater than 5, you will administer a vitamin K shot because we don't want these people to bleed out. And then, of course, we're going to decrease the dose and recheck in 3 days. Now, AFib, we talked about how atrial fibrillation, how it can be the TSH. If it's a new onset, that is the things that you're going to pick for a new onset of atrial fibrillation. You're going to check their TSH level because we know hyperthyroidism is very indicative or a causative factor for atrial fibrillation. We also know that electrolyte imbalances, our calcium, our magnesium, our potassium, those all affect our heart muscles. And it can cause us to go into an irregular rhythm, as well as dehydration, sepsis, infection. So we check UA, CBC, TSH. We also want to check their renal failure or their renal function. So you will need to know those for your exam. If you have a patient come in and their lipids are elevated, and you start them on simvastatin or lovastatin, you need to make sure that you educate them to avoid grapefruit juice. It will directly affect the medication. You also need to not give them macrolides. Why? Because we already have that going through the liver and it can be hard. But they do interact with macrolides. If they come in and they call, make an appointment, and you look and you recently started them on statins and they're complaining of muscle pain and don't feel good, and you come in, you do a urinalysis, or they say, oh, my urine is so dark, you need to be looking at rhabdo. It is very high risk with our statins with their liver for rhabdomyolysis. We don't necessarily want to take them off of that, but if they do have a dark urine, we're going to hydrate them and we're going to change that medication. it's critical. So, I mean, again, if they have dark urine, we've got to flush that out. If you have a patient who comes in and they're complaining they don't feel well, and this is going to take us right on into cardiac and hypertension, guys. So, and they come in and they don't feel well, and they just kind of feel lightheaded, and it comes and it goes, and sometimes they feel like they're going to pass out, other times they feel like they're okay, and you take their blood pressure, and it's abnormal, and then it's normal, and then you have them take a deep breath in right before you take it. Listen, it's classic case of pulsus paradoxus. These patients, their blood pressure will drop by 20. When you have them take a deep breath in, that heart can't move. Remember, it looks like a bottle with pulsus paradoxus. So their blood pressure is going to drop. There's going to be pressure, but it is going to be greater than 20. This will cause these people to have a high risk for falls. And they'll have to be admitted to the hospital. So it's a classic casebook question. If you have a patient and when you note that when they take a deep breath in, that their blood pressure drops by 20, you should be looking at pulsus paradoxus. Because basically we can take a deep breath in and our diaphragm moves up, and it doesn't really so much as affect our blood pressure. But think about if the question says that they take a deep breath in and their blood pressure drops and the diaphragm moves up, their heart's twisted, it's cutting off. They can't function like they were to begin with. But it's a classic case of pulsus paradoxus, and it's a medical emergency. We went over myocardial infarction. Remember, it's just EKG will show an ST elevation. Now, we talked a little bit about hypertension, so we're going to jump back into that once more. Hypertension for JN8 purposes, it is effective on this exam, is that the target range for an elderly is 150/90. We used to have it lower, however, we have contributed that to falls and dizziness, and let's face it, the elderly, they are higher risk for fractures, for mortality if they fall. A hip fracture can cause serious issues and can put them into shock. We've actually seen patients that have fell and they have fractures and they don't recover from those, and let's be preventative. So let's change the guidelines and increase it. So 150/90 for elderly. And if you have a patient who comes in and you're treating them for hypertension, and it's an elderly patient, and they have a heart rate, or their blood pressure is, say, 180/60. So, okay, so 60 is fine. That's our guideline. But they're 180, and that's out of what we want. We want 150/90. So, what do we give these? This is called isolated systolic hypertension. We treat that with calcium channel blockers. Okay, we want to open it up. And you will need to know that. It will be a presentation, and you'll need to know that that is isolated systolic hypertension, and that is treated with calcium channel blockers. If you have a patient and it is a woman and she has hypertension, but she also has osteoporosis, we do know that the medication of choice is thiazides. Why? Because they slow down the calcium depletion. And the way that I refer to this is when I think of thiazides, I think of salt. And salt and calcium, Na and calcium, they interchange. So it would do nothing but help us keep that calcium in. So for osteoporosis, hypertension is always thiazides. You also need to know that if you have a patient who has peripheral artery disease, that our test that we do is an ABI. That's Achilles brachial index. It's basically just putting the blood pressure cuff on and comparing the blood pressure in the lower part of the leg and the blood pressure in the upper part of the leg. Based on that, we can determine whether or not there is a decrease in circulation. It is necessary to do this before that you put on TED hose or treat a patient for edema. We need to know what kind of circulation do we have there. In regards to going right on into Raynaud's, this is those people that have, I actually worked with a girl who had this, the tips of their fingers will all become white. They're just white. They get cold, and they can be out in the cold for a little bit and they'll be white, and it causes them some pain. So we need to educate them that they can use hand warmers, always wear gloves, try to avoid temperatures because of course they could get burnt. But we also want to treat them with what opens everything up, those good old calcium channel blockers. So if we're wanting to open everything up, we want to open the circulation, we want to use calcium channel blockers, especially with our Raynaud's. They vasodilate. If you have a patient and you are doing an assessment and you hear a click in their heart, you should automatically be thinking of mitral valve prolapse. And think about it. I mean, if you hear a click, it's kind of like it's getting stuck. It's making a sound, okay? So if it's doing that, it's prolapsing. It's not completely opening up, and it's not completely opening and closing necessarily like it's supposed to. So if you hear a click, that is mitral valve prolapse, especially if they're symptomatic, and some can be. Sometimes they'll feel it kind of like flutter and then go away. Especially if they bend over, they'll feel it. So pay close attention to any patient or case scenario where it involves someone complaining of feeling like the heart just kind of stopped for a minute, or you do your assessment and they have a click, or they bend over and they can feel it. You should be thinking mitral valve prolapse. And you want to do your echocardiograms. Okay, so let's go right on into pulmonary, guys. This is the asthma and COPD kind of condensed down what you need to know. Crash course. So you basically know that asthma and COPD, we kind of did this the other day. Yesterday, I believe, because I'm wrapping up today. That the treatment for asthma and COPD are complete opposite of each other. So you're going to basically both start them with SABAs. But for an asthma patient, you need to know that, especially step 3, they like step 3. But if for step 2, you are dealing with an asthma patient, and this is someone who comes in and they got asthma, so you start them on a SABA automatically. And let's say they come in and their symptoms they're not daily, but they're every so often, and it involves nighttime. So this is when we're going to start in our low dose inhaled corticosteroid. When it involves, and in your case scenario, it's going to say that it involves day and night. That is when you want to add your inhaled corticosteroid. Now, if it is just during the day, of course, we can look at our SABAs and do our FEV1s. That's our test. Do our pulmonary test, especially before we do any medications. If you have someone who comes in and they're getting this is step 3, and which is the one that they like to ask, and let's say it's not under control. They've got symptoms that is occurring during the day. They have nighttime symptoms. They're coughing, shortness of breath. It's not every night, but it's more frequent than it was. This is when we want to add, either increase the inhaled corticosteroid to the next level, or we want to add a LABA. Okay, so for asthma, you're doing your SABAs, inhaled corticosteroids, LABA. A lot of times people do silly kid for asthma. Your COPD is the opposite, okay? We don't want to do inhaled corticosteroids to the end. You do a SABA, a LABA, and then inhaled corticosteroids, sorry. And the reason why we do that is because, again, COPD is a chronic thing, all right? So these people have probably had exacerbations. They've been on prednisone. We know that it causes osteoporosis and breaks the body down when they're on it for a long period of time. So we want to use that when we absolutely have to, okay, with your COPDers. Asthma patients, these are younger kids. So, of course, their immune system isn't like ours. We want to protect those lungs. So we're going to start younger when they have asthma, and we're going to go ahead and give them the inhaled corticosteroid because they're still growing. And then we do our LABAs last, okay? So just remember for exam, you're only going to have one question of each. And it's going to be, they're explaining to asthma patient. Just remember, step 3 is during the day and night. And you either, if they're on an inhaled corticosteroid, you increase it or add a LABA, okay? More than likely, we add a LABA. So community-acquired pneumonia, this is also called CAP. These are your patients that you will have, they've gotten it out in the community. They'll complain of rust-colored sputum. We know rust-colored sputum is automatically strep. Automatically, guys. And it's going to say that for your exam. It's going to say community-acquired pneumonia, or it's going to say a patient comes in, cough, fever, and rust-colored sputum. You automatically think strep. And if we're thinking strep, we should automatically be thinking pneumonia, okay? So you're going to be doing chest x-rays. It is the gold standard. Treatment for this, community-acquired. Now, this is azithromycin, your macrolides. If a patient had been on an antibiotic 3 months, or let's say they're allergic to macrolides, you can do doxycycline or levaquin. Levaquin is your last choice. It is the kill-all drug, but that's only if they are truly allergic to macrolides. And you need to ask them. You need to ask them what happens with their allergies. Because remember, if they say, oh, I break out in this rash, okay, well, describe the rash. Because if it's a multibiliform rash, meaning it's just kind of flat, there's no raised area, that's not a true allergy. Yeah, it can bother them, but you can give them Benadryl with it. Now, if they say that they're having trouble breathing or they had chest pain, absolutely add it and go straight to your doxycycline. But pneumonia community acquired is going to say rust-colored sputum. It's going to be strep. You should already be thinking strep with rust. I don't know why. Maybe if I say it enough, it'll get in like how I remembered it. Strep is rust-colored sputum. And again, chest x-ray is gold standard, and we do macrolides, which is your azithromycin. Now, let's go into a patient, let's say an elderly patient has pneumonia. And this is an elderly patient, and they may say, they're not going to say elderly. Let's say they have a 66-year-old woman comes into the emergency room or urgent care or your office, and she is complaining of cough that won't go away. She's been coughing up sputum. Maybe she even brought a sample to you. I'm not sure. Or she states it's like a rust-colored. You should be thinking pneumonia. Now, with the look at your patient population. If you're dealing with the elderly, we need to apply CURB 65. Now, we know that they only have to have one other point plus being over 65. So you need to know that if they're over 65, so if your case scenario says a 66-year-old, Okay, so we already met the criteria for the 65. Now let's see if the symptoms they provided qualify for CURB, and that is confusion, urea, respiration, breathing, CURB, breathing, or blood pressure. I'm sorry, blood pressure. So if their blood pressure is say 90/60, boom. 66-year-old, pneumonia, rust-colored sputum, and her blood pressure is 80/60. She's admitted. Okay, so let's say that she's 66, blood pressure is 110/60, because remember, you got to have this criteria. So let's say in this scenario, they say she's 66, so you're already thinking, okay, well, rust color sputum, that's pneumonia, okay. So we need to apply CURB 65, okay. She's 66, so that applies. She's not confused. You do your mini mental. She is aware of the date, time, where she's at, and what she's doing. Her blood tests come back, her urea is fine. Her respirations are about 20, 22. And her blood pressure, we already discussed, was like 110/60. She does not meet the criteria to be admitted. They must meet that criteria. They have to have 1 point plus being over 65. So if they don't meet the criteria, you're not going to pick the one that says hospital. You're going to pick the one that says you're going to treat it, which is your azithromycins. You know, and if it's an elderly patient, you may have to, or if they've had macrolides in the last 30 days, you may have to go to Levaquin. Okay, so let's go on down to your atypical pneumonia. This is going to be a classic casebook where this patient is walking around. It's basically a college student. It could be just a young person. It could be, I don't know, someone who just got out in the work field, started working at a hospital, a nurse intern, somebody that it's just atypical. And typically they list that it's someone in their 20s, and you associate with like college student. So it's not your typical patient. You know, our typical patients that we see with pneumonia are immunocompromised or older elderly patients, not our young healthy ones. So that's why it's called atypical, also known as walking pneumonia. So this is basically your mycoplasmas. These are your college students. They're typically they're otherwise very healthy. They may report that for several weeks they've had a cough, and now they've got a fever. They just don't feel good. They try to treat themselves at home. It didn't work out. They've taken antitussives. They've taken cough medicine. And it's basically like a cold flu symptom thing that does not go away. Okay, so if you have an atypical pneumonia, it comes back, it's pneumonia. We know it's mycoplasma. He's otherwise healthy. We're going to treat with azithromycin. Remember, atypical pneumonia, atypical patient, because typically with pneumonia we see immunocompromised or elderly. So atypical patient, azithromycin, AAA. That's how I remember it. Now let's go into somebody who comes in. Maybe this is, and you'll need to, I'll add this in because they've kind of included it now, but vaping. Let's say you have a young person come in and they're smoking or they're vaping and they're coughing and they're hacking, and you've talked to them and they said, well, they recently started smoking, and you listen to their lungs, they're otherwise okay, but the cough is mainly dry. It can be productive, and they could have a fever, not necessarily, but the color of the sputum will not be, it will be clear. Okay, so this person's having problem having a cough that won't go away, and basically just recently started smoking. So this is your acute bronchitis. These are also can be people that don't smoke. Let's say you go visit family and they smoke in their house and you don't smoke, and you start coughing and hacking and you can't get rid of it, and it's like spasmodic. Okay, you could be acute bronchitis. So we just need to do education. We do not treat with antibiotics, guys. These patients, we need to talk about smoking cessation. We need to determine what they've been doing to stay away from secondhand smoke. We also need to maybe administer guaifenesin or, just treat the symptoms, fluids, rest. We can give them an albuterol inhaler. That's probably the preferred treatment that you should see with, as far as medication with acute bronchitis. And that's just because we want to open it up and give them some symptom relief. So for exam purposes, please, please, please do not pick antibiotic for acute bronchitis. Remember, their sputum is going to be clear, otherwise healthy, cough, no collar, recently been around someone who smokes or they smoke. So you're going to treat them with albuterol. So let's go into whooping cough. Now, typically we've seen this with our younger generations, but we have seen geriatric patients come with it. But it's going to be a classic case. You're doing your assessment, it's a patient, and their cough is whooping. I don't care whatever else is in that scenario, guys. I'm telling you, it is whooping cough, pertussis. How we definitively diagnose it is what you need to know. Okay, so if you have a patient and they describe that the assessment is a whooping cough, and you see that they include anything else, I don't care if they say that they have a fever or they're late on their vaccinations. You see whooping in that scenario, you automatically better be thinking pertussis. Okay, and the only way that we definitively diagnose that is we do the nasal swab. Okay, and that's for the polymerase chain reaction, PCR. And of course, we're going to talk to them. Have you had your vaccinations? The importance of the vaccination. If they don't have a high fever, we can, administer that if they don't have, if they've not had it. And we need to prescribe azithromycin. So that's your macrolides again. We can give a booster of Tdap if we need to. And that's just basically, men get, in my little scenario, I do boys get boosted to men or humans get boosted to men. And that's basically your 11 to 18 year olds. So booster 11 to 18. We can give them, stuff to break up the mucus, mucolytics. We can give them antitussives that'll help with their cough, rest, hydration, small meals, don't overeat. Those are things that we need to educate them on. Because we don't want an epidemic, and we need to, the main thing is being prevention, but we may have to in this case if they come in and they have whooping cough, we know we need to look at the pertussis. Tuberculosis, you need to know the high risk groups. These are your immunocompromised, your immigrants, your HIV patients, your illegal drug users, nursing home patients, medical workers. We're exposed to that. This is why it's so important for us to as soon as a patient is admitted, to perform a PPD. We need to know what are the signs and symptoms. Well, if you have a case scenario, remember, we're all, nurses, and we've all had to have this PPD test. So, they ask you, do you have night sweats, anorexia, lost weight, unintentional? Think of those questions, guys, because those are the symptoms they're coming in with. Anorexia, weight loss, unintended, night sweats. So if you do, they come in with that and you suspect TB. So of course that we're going to do a chest x-ray. What will we see on that chest x-ray, guys? Remember, this is going to be the cavity, the black little holes. You need to know that because it's going to tell you for the ANCC, you're going to see it on the lobe of the lung. You're going to have like the little black spots, what we call cavities. But for the AANP, guys, it's going to be descriptive. It's going to tell you the chest x-ray is noted and that you see black cavities. If you have a PPD result and remember, we just look at in duration, right? That's all we care about, if it's indurated. For someone who's been exposed to TB, that is 5 mm's. That is your, like nursing home patients who say that their roommate's already being treated, so we already know they've been exposed. So once they hit 5, we know it's positive. So we do the chest x-ray. Now, the definitive gold standard for TB is we're going to do the sputum, okay? And it's going to be on 3 different days. You also need to know that the drugs that we use for that, and we went over that, you need to know that there's 4 different drugs. Usually rifampin UC is very popular. And the ethambutol and the pyrizolamine. And they'll do that 3 times a week. For HIV patients with TB, again, they're immunocompromised. They don't have to have that big 10. It's just 5. You need to know which ones are 5. So we've got immunocompromised, immigrants, workers, people are been exposed, close contact, recent contact. Those are the ones that are 5. For 10, that's us, workers. If they've been a recent immigrant, but they haven't been exposed, then we're gonna look at the last 10 years, or we're gonna look for 10 mm's. Let's go right on into the renal system, guys. So, I'm sorry, not the renal system. We're going to talk about primary hyperthyroidism. Okay, so hypothyroidism, or hyperthyroidism, also called or referred to as thyrotoxicosis. This is a very low TSH, which is on the exam they're going to give you lab values. Okay, if they have a low TSH, but they have a high free T4, T3, we need to rule out Graves' disease. Okay, we need to check for the specific antibodies for that. We will treat with PTU, which we know that shrinks the thyroid gland and decreases hormone production. If you have someone with primary hypothyroidism, this is someone who has a high TSH and a low T4, you're going to rule out Hashimoto. So on the exam, they're going to give you a big case scenario, they're going to give you a big CBC panel, and then they're going to give you TSH and T3 results, and it's either going to be a low TSH with a high T4, or it's going to be a high TSH with a low T4. And you need to know which one you're looking at. You need to know, for hyperthyroidism, we've got to worry about issues with tumors, and with hyperthyroidism, we need to look at Hashimoto's. So we rule out Graves' disease with hyperthyroidism, and we rule out Hashimoto's. Now, if somebody has a high TSH and a low T4, what is the treatment for that? That's when we start the Synthroid, okay? We need to start with the lowest dose, especially with elderly. They don't filter things like they used to, or like we used to. When we're younger, we can filter things, but as we get older, the normal aging process, the renal system is depleted. The liver's not much touched, and we'll go into that with geriatric, but we have to watch the renal system. Okay, so we start with the lowest dose, which would be Synthroid 12.5. You can increase the Synthroid every couple of weeks, but you have got to keep watch onto the TSH. Okay, know that. Know that the TSH is what we monitor. Okay, so that's it in a nutshell with hyperthyroidism, hypothyroidism. What are you ruling out, and what is your treatment? Hypothyroidism, remember, the thyroid is opposite. So if they say it's a high TSH, you're looking at hypo. If it's a low TSH, you're looking at hyper. We know with hypothyroidism, we put them on Synthroid. We know with hyperthyroidism, we got to look and make sure there's no tumors or what's going on and further investigate. And that is an ultrasound or biopsy, but more than likely an ultrasound. Thyroid. Radio uptake. Radioiodine uptake, my apologies. And then that will probably result in Synthroid for life. Okay, so let's go into diabetes, guys. Okay, so for exam purposes, diabetes, you have to know that if a patient's A1C is greater than 9, you have to start basal insulin. You have to. If you have a A1C that is greater than 6.5, we start metformin. We need to know, we need to educate on lifestyle modifications, weight loss, sugar intake. We need to check their feet. You have to check their feet every visit. You have to have them get their eyes checked, have them into a podiatrist. And then if they have to have any kind of IV dye testing, you have to know, we hold metformin 24 hours before the exam and 48 hours after. Okay, that will, hint, need to know that. 24 hours for metformin before an IV dye test, like an angiogram, and then 48 hours after, because we don't want that to get in that system and build up and just drop their sugar. So let's go into two different scenarios that you need to know in regards to diabetes. So we have what's called the Dawn phenomena, and we have the Samoji effect. They're going to give you some kind of scenario, and it's going to be basically like this. If you have a patient whose their blood sugar, let's say, was 200 at nighttime, you gave them the insulin, and then by morning it's like 3 something, and you're like, what the heck? Because you gave them insulin. They didn't have anything through the night. So how did their sugar go up? Guys, this is the Samoji effect. This is called rebound hyperglycemia. And basically what happened was, by, through the night, their blood sugar dropped so low that it bounced back up. Okay? So the insulin was too high. It was too much for the body to handle, so it just rebounded and came back up. This is when you're going to answer the question that you're going to adjust the bedtime medicine. Okay, remember, the blood sugar was okay or just slightly elevated when you gave them their bedtime medicine, but by morning, it was sky high. Rebound, hyperglycemia, decrease, nighttime dose. That's the one you're going to pick. Now, let's go into Samoji effect. Sorry, that was the Samoji effect. Let's go into Dawn phenomena. Okay. These are patients who, they wake up and they cannot keep up with the demands. They wake up and their blood sugar is so low, and basically their blood sugar drops. I mean, they have to have their medications. They can't keep up with the demands of the insulin. So around 4 or 5 in the morning, these patients, okay, never mind. These patients' blood sugar drops in the middle of the night. And this is when you want to talk to them and find out if they're having a snack, okay? So that is very important. Okay, so I'm going to kind of give you a question that you will need to know. It kind of gives this in scenario, sorry. A patient with type 1 diabetes is on regular insulin and NPH insulin twice a day. The first dose is injected before breakfast, and the second dose is injected at bedtime. The blood sugar results from the patient's diary show that the lunchtime values are higher than normal. Which insulin should be decreased? This is the type of question you're going to see on here. This is a case scenario, so you got to be able to break it down, okay? The NPH component of the morning dose should be increased. Why? Okay, so we looked, let's break this down. The lunchtime values are higher than normal. Regular insulin peaks between breakfast and lunch, but the NPH can peak between 6 and 14 hours. Therefore, we have to cover that postprandial spike, okay? So, increase the morning dose, okay? Because if we do it at the lunch dose or the bedtime dose, that's not going to affect the lunchtime. It's the morning dose. So, we need to increase it. That's the type of question you're going to see, guys. So, you have to know your insulins, not know them by name, but you have to know how it affects the body. All right, guys, so let's go into GI. Hold on one second. Okay, guys, let's run right into GI. Okay, so for the exam purposes, we are going to do this crash course, and it's going to go through everything in the GI and deal exactly with what we need to know. Okay, so if you have a patient that comes in and they complain that they had umbilical pain, and then it moved to the right lower quadrant, okay, you perform and note that the psoas and the obturator is positive. You automatically should be thinking in your head on this exam, that's appendicitis. It's going to be conclusive when they tell you that there is pain elicited at McBurney's point. You have to know where that's at, okay? McBurney's point is above the iliac crest. You're going to see that. You're going to need to know that. So, you also need to know these tests. So let's talk a little bit about them. So when we're doing an assessment on a patient who's in our office and we think that they may have appendicitis, we can push on the opposite side of their belly and see if pain is elicited, okay? Obturator is when they're laying on their side and you try to push up with their leg. Those are two signs you need to know. Patient is laying subline and is positive with the hip, you're moving the hip inward. They're going to complain of pain. And then again, you know, the Rovzeng sign, it is you're pushing on the opposite side that hurts, and it's elicited on the right side. You're going to have to send this patient to the ER. We actually did these two signs on a patient during clinicals, and it wasn't really conclusive. So we had him kind of like, kind of jump down off of the exam table. Not really jump, but, you know, like come down. And it pushed up on that iliac crest enough that he was in dire pain. And we sent him to the ER. He ended up having emergency surgery. So be very careful. Make sure you do all your signs, and make sure that you know what each one of them are. Okay, moving right along. So that pain actually started in the periumbilical area and radiated to the right lower quadrant. All right, so let's say we have a patient who's complaining of right upper quadrant pain. All right, guys. There is a picture I included on that I sent you guys that states what we should look at in the right upper quadrant. But what do we know? God, excuse me. What do we know is there? Okay, we've got gallbladder, we've got liver. We also know that it can have anything to do with the lung. But they're going to come, it's going to be a scenario where it's going to talk about they just ate a fatty meal. We know that we used to refer to it around Thanksgiving as gallbladder season. It was just, we ate those fatty meals, we had that turkey and gravy and that dressing, and everybody came in with right upper quadrant pain. Now, when we do that the assessment, we may even be able to palpate that there is some fluid around there. Remember, if to palpate any kind of ascites as a secondary issue, you're going to hear some tympany in there. You can hear it kind of moving when you're listening with your stethoscope. But these patients will need to have what is like gallbladder ultrasound. Sometimes these patients will have a stone. Please know that the Latin sign of any kind of liver problem is jaundice. Okay, when we look in their sclera, and for African Americans, we look in their mouth. But know that for acute gallbladder attack is those who come in after eating a fatty meal. It's usually around, again, holiday season. They will be nauseous. They don't necessarily have a fever, but they may have had some pain in the past, and they just kind of overlooked it. But they can have an acute attack, and I've seen patients have gallbladder full of stones, and just know that they'll do like a ejection fraction and see how well it's functioning, and more than likely the blockage will be taken care of, or this patient will require surgery. So again, if you have a positive for that, you send to the ER. Okay, acute pancreatitis. These people are going to have pain on their left side, or they may refer to it as a boring pain in their back. Now remember, the pancreas is right here on the left-hand side, but if it's boring in their back, like boring, we need to be worried about pancreatitis. And this is pretty serious because people can get sepsis from this, and I've seen people actually die from this. These people have an acute onset of fever and nauseous and vomiting. And the pain, now that alone, fever, nausea, and vomiting can be a number of things. But if they tell you that they're having associated, like my back is killing me back in here, okay, well, then we can look at pyelonephritis. But the fact that they say it's boring, it's like digging in, that's not pyelonephritis. That is pancreatitis. Okay, so you need to look at, do some levels, check your LFTs. You're going to see an AST, an ALT, lipase, amylase. They're all going to be elevated. This patient will be hospitalized because it is very critical and we have to take care of it. You see this a lot with like rebound alcoholics for the most part. But now sometimes people just have it if they have any kind of illness or immunocompromised, they can get pancreatitis. Now, if you have a case scenario that says that there is a blue discoloration at the umbilicus, we should automatically know that's a colon sign. Gray-Turner sign can also be positive, and that's the gray color. Okay, so know those those signs: colon and sorry, let me get back here to my study guide. Colon and Gray-Turner syndrome. Hey, yeah, that's just pretty much colons. I just think of color blue, and Gray-Turner I think of gray-blue. But know those two signs, because they're not going to ask you to answer that. They're going to tell you that they're positive. So you need to associate that with the pancreatitis. Okay, so let's talk about some issues with the abdomen, a patient comes in, they've recently been on an antibiotic, that should already be getting your mind thinking. They've recently been on an antibiotic, diarrhea, fatigue, just weak, and it foul smelling stool. Foul smelling stool, recently on antibiotic, you should all maybe be thinking C. diff. We have to catch this right away because it is so contagious and it's so life-threatening. So these patients, we need to test it for C. diff. Everything has to be clean with pure bleach because that's the only thing that can kill it. And it's usually those patients who they've recently been on an antibiotic for and it's been 5 or 10 days. It can be up to 2 weeks after they've had an antibiotic. But if they tell you that they have abdominal pain, there's some bloating, and that the diarrhea is just foul smelling, it is the worst they've ever smelled, and they just go and go and go, then you need to be looking at C. diff, which is Clostridium difficile. If you have a patient who is complaining of abdominal pain and or even doesn't complain of abdominal pain, because you're going to be doing your screenings on some of these patients, and one of them is colon, and so you have them do the occult stools, and the little cards, and it comes back positive for blood. You're going to refer that patient out for a colonoscopy because we need to be thinking colon cancer. In association with that, you need to be thinking if someone complains of pencil-like stools, you should automatically be thinking of descending colon cancer. Hint, hint. Ulcerative colitis. Ulcerative colitis is bloody stool. These people go 10 to 20 times a day. It's an inflammatory bowel disease. They have severe cramping. They're high risk for toxic megacolon because, think about it. If they're going this much and they've got, and it's inflammatory, then we know with inflammation that things can swell up and that can cause a toxic megacolon. And that's life-threatening. These people, if it bursts or erupts, then they can start vomiting stool. Ulcerative colitis is lifetime. Unfortunately, we treat symptoms. There are new drugs out. I used to teach Humira injections to patients, and they were getting younger and younger with ulcerative colitis. So these patients will need to see a gastroenterologist if they have this bloody diarrhea, and they can be different ages. Guys, I've seen them younger, but these people will have bloody diarrhea, and it's basically because the inflammation of the intestines, and it's very vascular. So, we should automatically be thinking they have these stools and there's blood involved. There's something bleeding inside. And so that's either inflammation or, it's rubbing something. They could have a blockage. Depending on the collar, because, you have to worry about GI bleed. But for the most part, with ulcerative colitis, they're going to say there are 10 to 20 stools a day. And they just go when there's bloody diarrhea. So just look at what they're telling you in the scenario, okay? No matter how many sentences, I can't tell you enough. If you associate yourself with the knowing that, like in the case of ulcerative colitis, these are people that go 10 to 20 times a day, and bloody stools, but they're not saying that they have a foul smell. So that should automatically kick out C. diff. And you should be looking at these patients for ulcerative colitis. So that's a little bit different of the differentiation with bloody stools. And they're not complaining that they're constipated, which you'll see in the elderly with bloody stools. So let's go into Zollinger-Ellison syndrome. Okay, so this one kind of popped up. I've heard a little bit about it, but it did pop up on some reviews that I've done and some of people that's taken the exam. So this is basically ulcers that occur on the stomach for we have no idea what reason. Okay, there's no reason for the syndrome. These people are just getting ulcerations in their stomach. This is called Zollinger-Ellison syndrome. Okay, so you just need to know that it is basically ulcers in the stomach for no known reason. This isn't like it has a toxic megacolon. It doesn't. These are not people who are having multiple stools a day or anything like that. It's just basically they're having severe stomach pain, and when they do an EGD, they see all these little teeny ulcers in the stomach, and it's basically like they're associated with tumors, and what they're associated with is that these ulcerations are from tumors from an increased level of gastrin, and that's our gastric content, and an enzyme. We just don't know why. So when you see that on your exam for unknown reason, ulcers or tumors, you should be thinking Zollinger-Ellison syndrome. Acid reflux, let's go right into that. What you need to know, this is basically first line treatment is H2 antagonists. Okay, so we're going to get into this really quick. Acid reflux, guys, you do not want to give them calcium channel blockers. We know that with calcium channel blockers, they open everything up. We do not want to give them calcium channel blockers if they have hypertension. Be very careful when you're prescribing hypertension medicine that you're looking at their past medical history. Because if not, and you give a calcium channel blocker to, which is not even the first line, but if you give them a calcium channel blocker, and you're going to get a phone call that they're going to come back in because their acid reflux is going to be out of this world. And we don't want to do that, because what do we associate acid reflux with? We associate that with Barrett's esophagus. And Barrett's esophagus can turn into esophageal cancer. So we have got to break the chain. Okay, so we have to be educated and apply that. Now, for board purposes, be very careful, because when they give you a case scenario, they are going to tell you if it's H. pylori positive or H. pylori negative, because we know that an EGD is what we do to, not we do, but you know, what a gastroenterologist will do to determine what's going on down there. So if they do an EGD with biopsy, and it comes back H. pylori negative, this patient has acid reflux. So of course, we're just going to put them on the first line treatment. For exam purposes, it's H2 antagonists. It has not taken effect yet with PPI. PPI is what you should already be implementing after you take your boards. Irregardless if it has changed on the exam, it's already in effect, okay? So we prescribe PPI, but for medical exam, it's H2 antagonists. Now, if you have an EGD and the biopsy comes back, it's H. pylori positive, this patient will need to be on triple therapy as well as a omeprazole. So make sure that you pay close attention to whether it's H. pylori positive or negative. Okay, so irritable bowel syndrome. A lot of people have this, especially like in grad school, and anytime that we're stressed out, okay? And that's basically where we go through periods of diarrhea, and then we could go constipated just days later. And basically, the only thing you can do is put yourself on a diet, or tell your patients to choose foods that's not going to make them constipated, if they're constipated, like wheat, or if they are having diarrhea, citrus, avoid citrus. But you also want to talk about stress. You want to try and get them to include fiber in their diet, so it kind of keeps them on a plane. A lot of times they'll put them on Miralax, and that's just simply just to keep the stool soft. But irritable bowel syndrome, just remember, is when they have both diarrhea and constipation. And that's basically it. It's just probably something they're going through at the time. Peptic ulcer disease. So let's go into that. This is where we have ulcers. And this is where you see patients who they'll complain of their belly. It's just like burning. And it's really bad when they eat like spicy hot foods. So of course, we're going to send these patients to an EGD or to an gastroenterologist. But we're also going to make sure that these patients are having their tests done and decrease in stress, because stress is the number one reason, or it's not the number one reason, actually NSAIDs is the number one reason for ulcers, because we know that they directly can cause GI bleeds. But next to that is stress, people who worry. And I think that it goes along with gastrin, that's the enzyme there. So, I mean, think about it for just a hot second. But when you get nervous, people get diarrhea. That's our sympathetic nervous system kicking in. So it's only to think that ulcers can also be caused from excessive stress, because if we're stressed or crying or we're just in this relationship or this state of mind where we are constantly just worrying, then we are constantly got our stomach in an uproar, and we're stimulating that nervous system, that sympathetic nervous system, to kick in. And when it does, we've got juices and gastrin and enzymes, and so that can be ulcerated because that is very acidic. Peptic ulcer disease, we basically want to talk to them about education. We want to talk to them about de-stressing, but we also might want to put them on something to help them with that ulcer after they have had the EGD. Well, we don't necessarily put them on something, but look for them to be on something, because we want to refer that patient out. But if they have a history of peptic ulcer disease, make sure your patients are on acid reflux medicine. Make sure you're talking to them about stress. Make sure you're asking them how they're doing, because these people will still complain of burning. Make sure they keep their follow-up appointments. And just know that the gold standard when you're dealing with anybody with stomach issues is the EGD with biopsy. And again, triple therapy for H. pylori positive is your clarithromycin, your flagyl, flagyl, and amoxicillin. So the only difference is if you have to do a quadruple therapy, meaning that the triple therapy didn't work, which again, we refer these patients out. But if you're in a hospital setting, you may have to order this. So if you do a triple therapy and it comes back, it's H. pylori still positive, you're going to need to go to a quadruple therapy, which is where you add bismuth. And these people need to be on PPIs. Always make sure they're on PPIs. Remember, for exam, though, it's H2 antagonists. So let's talk about hepatitis C, guys. So if a patient comes back with hep C positive, these are your illegal drug users. These are people who have unprotected encounters. And these people are, have liver disease and damage. So if you have a patient who comes back with hep C positive, be sure you know that the next thing you're going to order is a viral load. Based on that viral load, will determine whether or not they can be treated, okay? So the treatment of choice for hep C now is Hervani, but they have to be at an elevation. Their viral load has to be at a certain elevation. So that will be the next test that you order, is their viral load. And that's actually an HCV RNA. HCV RNA. That's their viral load. Okay, so let's run into the renal system. This might end up being a little bit more than 3 hours, so I may have to switch it up and just break it up, so we'll see. But I need to get through every system. And lots of times I add extra stuff in there to help you remember. So, renal system, you have to know with the geriatric, the normal aging process is that the renal function has worked for so long, filtering out all this waste, that it has decreased the function. This is why that we hold that metformin so it doesn't get really, caught up in the whole decreased function with using an angiogram. This is also why we try and use medications that go through the liver and not the kidneys, because we take a high risk with it not filtering like it used to, that these people can become toxic. So just remember with the elderly that the decreased renal function is a normal aging process, but this is why it's so important for us to choose drugs that are through the liver, or simply make sure that we watch their BUN creatinine, and we actually do a creatinine clearance 24-hour urine. We do not use serum creatinine with the elderly to determine whether or not their kidney function, because it's not accurate. So let's go into acute renal failure. So this could be anybody, all right? So a lot of times people go into acute renal failure after they have started a new medication that's affected the renal system. They may have suffered from a heart attack. They may have got so severely dehydrated that their renal function is just overworked. In normal scenarios with acute renal failure, we can rehydrate and kind of kickstart that kidney. But sometimes, if it has to do with a diabetic or hypertensive patient, we have to do like a one-time dialysis, and we have to kind of filter it out ourselves and then get it healthy again. So acute renal failure, you need to know the signs of that, and that is basically fluid overload. Our body is not getting rid of the fluid. They will have an abrupt weight gain, usually more than a couple pounds a day. They will have edema. They'll be lethargic, nauseous, loss of appetite, completely feeling like they're full. And when we do check that EGFR, which you need to know, it's the best measure to check for acute renal failure. And that's the filtration rate. Okay, so let's say that somebody has a urinary tract infection, and this can happen, especially with younger generations. We're seeing it. These patients have a urinary tract infection, and let's say that they thought they were just peeing more. They weren't paying attention. They thought they were drinking more, so that's why they were peeing more. It had a odor to it, so they thought it was because they were holding it in. But what ends up happening is when a UTI is not treated, it ascends up. And when it does, it ascends up into the kidneys. Okay? This results in acute pyelonephritis. This is pretty serious, guys. These people will complain of just like maybe one-sided pain. They'll be nauseous. They may be vomiting. You're going to see a fever. Their CBC is going to be through the ceiling, but it's going to be basically acute, because once it hits the kidneys, they're going to be sick. So if you have a patient come in with unilateral back pain, deep, so we're thinking kidney, and then they have a fever and chills, automatically be looking at, not so, especially a younger person, not so much as just a UTI, we need to be thinking pyelonephritis, because more than likely this patient has had a UTI that wasn't treated, or they were treated and they didn't finish the antibiotic, because we know they're notorious for that, or the antibiotic didn't kill the bacteria all the way. These people will need to be on a 7-day antibiotic. Sometimes they have to go on IV antibiotics for 6 weeks, depending on how bad it is. If it's caught early, you can do a 7-day to 10-day. Remember, it's complicated. It's a complicated UTI. It can't be a 3-dayer. These are people that have to be on antibiotics like Cipro or Levaquin for 7 days. But if it is severe, they will need to have a port placed and be on antibiotics for 6 weeks, because it's pretty serious. Okay, so let's go into A UTI. Listen, you'll need to know this. If you do a urinalysis on a patient and it comes back that it is greater or multiple bacteria, that is a contaminated specimen, okay? You should not be having multiple or many bacteria. It's contaminated. You need to repeat it. If you have a child less than 3 years old who is having a UTI, we need to refer that patient because it is not common. These little girls should not be having UTI, okay? Pregnant women, UTI. We always check their urine. Why? Because they can be asymptomatic, but we have to treat them so that the infection doesn't go to the baby. Okay? And remember, the treatment for UTI is macrobid for mommies for the first and second trimester. By the third trimester, we're ready to kick that baby out, so let's do some Keflex. Same thing if they're breastfeeding because, they're giving the baby part of them, so we only use Keflex. So macrobid for mommies, first and second trimester, Keflex, kick the baby out, or breastfeeding. So a UTI in males is always complicated, always. Okay, so if you have a complicated UTI in males, they have to have a treatment for 10 days, all right? You also need to know that if a female states that she's using spermicide with condoms, you need to also know that she needs to be educated that it can increase the risk of a UTI. If it's uncomplicated, if she gets a UTI and she's used a spermicide and it's uncomplicated, meaning she doesn't have a fever or anything like that, you can do the Bactrim DS for 3 days. But if she has any symptoms or she's symptomatic, it has to be 7. And a man always has to be 10. All right, guys, let's run right into the nervous system. All right, so you have a patient that comes in, and I actually had my friend's mom do this the other day. She has some numbness right here, okay, and it was tender to the touch. It was kind of numb, but if they touched it, she had tender. It's one-sided. Listen, we need to worry about temporal arteriitis. The only treatment we need to know that it can cause them to go blind. We know that the to definitely diagnose it is biopsy. I actually had one doctor who removed a patient's artery right here when he didn't even try NSAIDs. So just remember, or high-dose steroids. Just remember that's the first line treatment is to try high-dose steroids, oxygen, but we need to worry about blindness. So we have to refer to the emergency room, well, you refer to emergency room, but they're going to refer them to an eye doctor. All right, so let's go into some of the questions that we ask ask our elderly is we do what's called the MMSE. Okay, so for exam purposes, they're going to tell you you're asking the patient what day of week it is. You're asking them to remember 3 words. You need to know that that's an MMSE, a mini mental exam. Okay, geriatric depression scale. Excuse me. That's the depression scale that we use to assess their depression. Stereogenesis or genosis. That is basically where you take like a paper clip. We had to do this in grad school, so I'm sure you did too. You had to put a paper clip in someone's hand with their eyes closed, and they had to tell you what it is. Okay? That's basically, it's going to be just cut dry that on the exam. You need to know with migraines. Let's go into migraines under neurology. Okay, so migraines, with or without aura, we know that the treatment is, abortive treatment is triptans, okay? Maintenance is propranolol or Inderal. That's all you need to know. Migraine is going to be one-sided. They're going to say it's throbbing behind the eye. They're going to be sensitive. And one of the mnemonics I came up with to remember migraines was, migraines make me trip on my feet. Let me see. Sorry, I hadn't said it for quite a while. Migraines make me trip on my feet, but I can maintain it by propping up my feet. Okay, so if you have a migraine, you know that you're sensitive, you don't feel good. So, trip on my feet, triptans, okay? So, but if I prop up my feet, I won't trip. So I can use propranolol or Enderol for maintenance, okay? Hope that works. Also know that for the exam, that if you have a patient come in and she wants to be on combined oral contraceptives, that one of the definitive contraindications is migraines. That is the one you pick. Migraines or headaches, okay? Trigeminal neuralgia. This is somebody who's going to complain of pain around their cheek, behind their eye. It's going to be sharp. And we treat that with Tegretol. And the thing I just remember is Tegretol for trigeminal, T for T. Okay? We need to worry about decreasing the pressure for intraocular pressure. With a cluster migraine, they're going to talk about piercing behind one eye. And remember, all migraines are one-sided. If they talk about a band-like or the entire head, we are talking about a tension headache. And that's grad school. They're going to tell you, you know, stress reduce, oxygen, but, you know, it doesn't help. When you're tense, you're tense. So it is the only one that talks about band-like or the entire head. All your migraines are going to be on one side. Cluster is going to be like an ice pick, just constantly. It's going to be something that they say happens the same time every day. So if you have somebody who comes in and says, I have this headache, and it's always right here. It happens every evening. I come home, it's not right here, but it's right here, or it's right here. It's behind my eye. Okay, same time of day. That's a cluster headache. Okay? Bell's palsy. My son had this not too long ago, so let me talk to you about this a little bit. Bell's palsy is basically one side of your face. It's basically your facial, it's cranial nerve 7. You'll need to know that. But it is paralyzed, and it can be immunocompromised, stress. His was basically, he had just got over an illness, and there was pressure there. The treatment is Aclovir and steroids. It's going to make him feel like crap, but I'm telling you, they have to take it. Steroids and the reason why we give Aclovir is because it's possibly herpes related, but not necessarily. So one of the things you need to know is they need to finish the treatment, and also there could be lingering effects from this. So with cranial nerve 7, like my son, it's all resolved. Like he can, you know, it took him a while, but he can smile and both sides move up and down. But this side was like flaccid. It's just one-sided. That's Bell's palsy. It's just stuck. And basically, when he eats now, his nose and his eye both water. That's like a lingering effect. They say he'll have that forever. So just know that if they come in and they have problems, even though they've got their facial movement back, that they can possibly have later symptoms with Bell palsy. Now, carpal tunnel. It's going to be classic case on this. It's going to talk about a patient coming in and they're dropping things. You may see that their trigger finger is pulled back like this, okay? But for the most thing, they're going to say they can't grab a hold of things. You're going to have them, and it may say that you're doing the Fallon sign. So remember, Fallon is praying hands upside down. When they have carpal tunnel, they can't do that, guys. It hurts so bad. All right? You also can tap on the nerve. And if it's positive, it's carpal tunnel. All right, so you're going to refer those patients out. So remember, carpal tunnel, we all probably know this, but we're dealing with the wrists, okay? So Phalen test, Phalen, is praying hands, and they're upside down. They can't do that. It hurts too bad. Okay, and that's probably what's wrong with mine a little bit. I don't have the trigger finger, but I think I have some carpal tunnel. All right, so let's go into hematology. This is the easiest way I can talk to you guys about anemias. Okay, so you need to remember for the exam, all right, that the gold standard for checking for sickle cell anemia, hint, hint, need to know, is hemoglobin electrophoresis. Okay, you need to know that. That's how we break it down so we can see that sickle cell is hemoglobin electrophoresis. Okay, so let's get into the anemias. So some of you guys have my little handout. Some of you don't. You can message me and I'll send it to you. But basically, you and I do this with my one-on-ones, go in more detail. But macro. Okay, so we're looking at MCV. When you get an anemia question, we are only looking at MCV. Okay, so that's a mean corpuscle volume. That's size. So if it's greater than 100, they're going to give you the normal values for the AANP. But if it's greater than 100, that's macro. If it's less than 80, that's micro. So bigger is macro. Smaller is micro. Okay? Now, in this group, if you visualize it, macro is greater than 100. Be patient, friends. That is B12, pernicious anemia, and thiamine. Folate. So, the whole diagram says be patient, friends. That's your macrocytic. They're going to tell you MCV, let's say 112. Oh, that's greater than 100. Okay? You should be looking at your macrocytics, or you should be looking at your macro group. That's your B12, your pernicious anemia, and folate. Be patient, friends. Micro is time. In time. It's 2. You only have to know 2. Okay? So if they tell you that the MCV is 66, you're dealing with microanemia, okay? Microcytic anemia. Microcytic is in time micro, okay? I just think of time as microseconds. So in time is iron deficiency anemia and thalassemia. All right, so let's say you're looking at, which one is it? Okay, I can tell you right now, they like this one's a little bit different, but if you remember, be patient, friends, in time. But they like to use B12. They want you to know what that is because there are so many people. But let's say you have iron deficiency anemia. We are looking at the RDW, which is that will tell us, how, if it's low, are we looking at iron? If it's high, are we looking at thalassemia? Or vice versa, okay? But for the most part, if you can read the MCV and know that the higher the number puts them in macro, the lower than 80 puts them in micro, you have just nailed it down to 2. And more than likely, they're not both going to be on there, okay? So, they're going to add something else in. So, let's say it's B12. What do we know about B12? B12 has a strawberry tongue. They also can have tingling in their lower extremities. Boom. They've not only told you the symptoms, they told you MCV. You see what I'm saying? You need to be able to critically think and look at your labs and be able to apply these anemias, and you'll do just fine. So, macro, micro, okay? If somebody wants my study guide with this, if they purchase the, they should get this. But this is for the crash course specific. So if you really want it for the crash course, you can just email me and I'll send you 65 pages long, just so you know. So, and it looks like we're going to go into 4 hours. I'm going to have to probably break here at 3 and finish up, break up at 3 hours and then finish the hour and then upload in 2 separate documents. Just because I do a 3-hour crash course, but I want to make sure I go over every single thing that you need to know for the exam and from the systems, specifically for the exam. All right, so let's go on. If you have a patient who the MCV is 76, this is what we were just talking about, okay? You need to know this for your exam. 76, okay, so that's less than 80, so we're dealing with microcytic anemia. So is it B12 or is it thalassemia? What is the next test? We're going to rule